Thank you, ma'am. A very good evening to everybody who's attending. Hi, Bansi, Anuj, Ashutosh, Pallavi, and thanks, Sinaji, for getting me on board again. Uh, you got the CV finally in time. So I was really excited when Ashutosh introduced the topic or the title for our 10th national conference, translating research into clinical practice. And just before me, Dr. Bansi really in such a well way uh, how how we are translating research through. He talked about Declare, the heart failure trial, CKD, how that is translating into a radical change in the way we treat diabetes, and is reflected in the guidelines with all international bodies endorsing changing the status or the way we treat diabetes with a end organ damage based approach. And that's how research is translating into the highest level of clinical practice. So congratulations to the entire team uh, for making this topic so important, because this is really going to translate into better care for our patients, how we are interpreting research and translating into the best clinical practice. So today's focus uh, is research and clinical practice, and the research work which I'm going to be presenting to you. It's very simple slides. I've tried to keep it as simple as possible because I wanted the essence of clinical practice to reflect more in this, and all of it is home done. When this is my second home, Vedanta. So whatever I'm going to be presenting here is totally been done as a team effort at Vedanta, and one of my senior colleagues is also going to be a part and be talking about NAFLD. So I showcase here the recent publications which have come out from our research group at Vedanta, and understanding how these two particular group of drugs, which are the SGLT2 inhibitors and the GLP-1 RAs, how they're going to translate into going beyond just the routine care that we deliver to our patients. And Bansi has also completed the line from where I would start running now, the show, which is diabetes control, multiple pleiotropic and benefits, cardiac benefits, heart failure benefits, CKD benefits, all these benefits he's done exceedingly well. Now I'm taking the baton and starting you on the new journey forward with these two particular drugs. A very brief introduction of non-alcoholic fatty liver disease. We all know how to define it. And there are a lot of talks as per the agenda about NFLD, the diagnostic, the clinical implications. So I'll be very brief here. As we can see here, that as compared to the general population, diabetics have a very high prevalence, almost double or triple, depending on the kind of diagnostic modality you utilize for diagnosing non-alcoholic fatty liver disease. As you see in the gray are general population and the black ones are diabetics, almost twice as much. And even using MRI quantification of liver fat, you see almost about nearing 60 to 70% of diabetics have non-alcoholic fatty liver disease. So once we, years back when we used to see patients, let's go back to undergraduation days, ultrasound report saying fatty liver, it would just be ignored as, so fatty liver hai, theek ho jayega, don't worry with that. But in the last 2-3 decades, world of evidence and experience has come into understanding a non-alcoholic fatty liver disease as a very strong, important uh, risk factor, kind of pre-diabetes state. It is a part of the pre-diabetes spectrum. The reason being, we'll just come to, and it is not just this, the so-called nascent non-alcoholic fatty liver disease. If you just screen the population and look at the outcomes of non-alcoholic fatty liver disease and quantify their or qualitatively assess their fibrosis by a fibroscan and using various scores or these tests which are now widely available, the vibration controlled transient elastography, which is commonly known as the fibroscan. You see that a lot of these patients with non-alcoholic fatty liver disease have got various level of fibrosis, and the next thing coming to them is something totally unsuspected by them, by their physicians, is chronicity of the liver disease, or further on going into more complications. So looking for these things, and I'm sure during the conference we'll have a lot of talks about how to wisely assess these patients, what are the risk factors in day-to-day practice, do we screen all of them? And the biggest example is all the diabetics we see in our OPDs. We do a whole lot of screening for complications of diabetes. Well, this is possibly now going to become a standard part of evaluation of all patients with at least with diabetes or multiple risk factor for future risk of diabetes. That is how important it is. And again, important fact of coexistence, the relationship of non-alcoholic fatty liver disease and type 2 diabetes is bidirectional, with one increasing the risk of the other, and it goes back and forth. The presence of type 2 diabetes, as I talked in the last slide, is that the so-called nascent fatty liver, which was kind of ignored in the past, it's clearly proven that it has a significant, very high percentage, especially in the Indian population, to translate into inflammation, which is steatohepatitis, increasing fibrosis, and by the diagnostic modalities I share, chronic liver disease, and hepatocellular carcinoma. We at Medanta have one of the largest liver transplant programs running, and believe me, we see so many of these patients coming to us post-transplant, and the reason for transplant is cryptogenic or NASH or non-alcoholic fatty liver disease related, and they go through their lives without any symptoms. And that's why it's extremely important to screen for these diseases. And we have a lot of discussions and debates going on about the screening. This is the liver part of non-alcoholic fatty liver disease and their possible outcomes in diabetics. Along with that, we have non-alcoholic fatty liver disease in diabetics, increasing the risk of cardiovascular disease, other complications, CKD. So we say that when a patient develops proteinuria, microalbuminuria, or increased urine albumin creatinine ratio, there is an increased overall cardiovascular renal risk to them. Well, similarly, presence of non-alcoholic fatty liver disease gives that kind of predictive for future complications of diabetes. And that is how important it is in diabetics to ensure if we have therapy, which is not just providing diabetes care, glycemic control, and as Dr. Bansi said in his discussion, that we are now protecting the heart, we are now protecting the kidneys. Do we have drugs which can go beyond that? Well, this is exactly what our research is showcased. And in the last slide, I'll see what it has translated into at the international level of the guidelines, which reflecting there. So there are two studies which I'm going to be sharing very briefly and very simply. One is on empagliflozin, the SGLT2 inhibitor, and other is the DLIF study, which is on dulaglutide. Both were focused on routine care. These are randomized controlled trials, open label, which were done in the real world scenario in the OPD at our center. And so we in this are assessing how these two particular drugs provide benefit to the liver health. The first study, the ELIF study, was published in Diabetes Care in 2018, where we used MRI to quantify the liver fat. And as you can see here, these are color-coded images obtained from the MRI. And you see here, these are the segments of the MRI. So look at this part, which is 2. Look at this part, which before starting the patient on empagliflozin had 30% quantified by the MRI, and in 20 weeks, it reduced to 7%. And similarly, another example where in this section, as you can see here, the segment 5 of the liver had 33% at the end of the study was 8%. So this is just reflecting how deep we have gone into the research mode, but we're doing it in the OPD practice in the department at Vedanta. And this is hard data about the benefits. We'll come to the numbers and the overall stats. So the baseline and post-treatment changes in the two groups, as we can see here, the anthropometric, the blood pressure parameters, we see significant differences within the groups for baseline and post-treatment with some reduction. However, the last group talks about, the last line talks about the control and EMPA group differences. All these values of benefits were similar. So they had good glycemic control. And why I'm spending an extra minute here, we intended to achieve a good glycemic equipoise in the two groups so that the results of glycemic control do not reflect in the changes in liver fat. So both these groups had very good glycemic control at the end of 20 weeks. The only significant difference in the control group and empagliflozin group was the reduction in the ALT levels, with beneficial effects, though not statistically significant, happening across the board on all these parameters, with very significant reduction in weight and A1C, but not different in between the two groups. The liver fat, when we quantified by the MRI, and the image of that we showed you right at the beginning, we have on the left the control group and the right the EMPA group. As we can see here, after termination of the 20 weeks, there was a reduction in fat. Now, these were patients who were getting standard of care, getting them to an optimal A1C, which at the beginning, a lot of them had A1Cs near 9. Despite that, there was some change of benefit, possibly because of intensive lifestyle changes which were offered to them. But here in the empagliflozin group, you see such a significant decline from 16% liver fat, this is the mean, coming down to 13%. And in between the two groups, there was a 4.2% reduction. Now, 4.2% reduction is a massive decrease in the quantum of fat. And we all know that fat is so metabolically, volatile. A lot of cytokines and all these things which are produced. So reduction of 4.2, though it seems to be a small number, but the benefits of this percentage loss of fat in the liver is possibly going to translate into a massive benefit, not just in the liver health, but overall cardiovascular and renal health. Yes, we need more studies into that. The only lab parameter as far as the liver is concerned, the ALT was significantly reduced. Within the groups, there was reduction, but in between the groups, intergroup, there was a significant reduction in the ALT, but with the GGT and the AST, also we see significant numerical declines happening, which did not reach statistical significance. Now, this is the most interesting part of the discussion. And when we go to the next study, which I'm going to be sharing with you, you'll find this even more interesting. And I'm sure it will generate numerous questions in your mind, some of which I may not be able to answer, to be very honest. So the correlations between changes in liver fat and A1C. So logic says that better A1C should translate into reduction in liver fat. However, though the numbers are not very large, but there was no correlation, as we can see here. There was no statistical correlation in between significant A1C reduction and the liver fat. So possibly in our study on empagliflozin in type 2 diabetics, the liver fat reduction was happening irrespective of the A1C change. We cannot generalize this statement, but it'll create more interest when you see here that the correlation did not happen again when the liver fat in between liver fat and weight, body weight reduction. So these patients, there was no correlation with body fat and liver fat. Again, against going the logical thing that we understand. So both group of patients did lose weight, some little bit more in the EMPA group. However, the, the liver fat reduction is not correlated with the weight reduction, and also the changes in the ALT levels and the body weight were not correlating, as we can see in the p-value. So the study results, if we had histology, more follow-up, we could possibly know more, indicated that dapagliflozin was when given as an anti-diabetic medication in these patients who had pre-existing non-alcoholic fatty liver disease without any contraindications to the disease, led to a good glycemic control, weight loss, a significant reduction in MRI quantified liver fat, with significant reductions in the ALT levels, with statistically non-significant reduction in the other liver enzymes, with no correlations existing in between the reduction. There were no predictors of reduction in the liver fat, like A1C reduction, reduction in the body weight. So on similar lines, this study again published in Diabetologia, where empagliflozin about liver enzymes, and it included, a lot of trials included EMPA-REG. We see the trial results similar to what we demonstrated over 20 weeks. Now, these are studies which are going up to 206 weeks, where significant reductions in the ALT levels have been documented. So possibly that we're looking at the other dimension of SGLT2 inhibitors, the liver safety aspect or liver benefit aspect of SGLT2 inhibitors. And like for HbA1c, like for weight reduction, SGLT2 inhibitors or any other drugs which cause these two effects, greater the starting point, greater is the reduction. And similarly, those who have greater, who fall in the third tertile would have a greater decline. These are how the drugs, greater the risk, greater the benefit, and that's what is shown in the lower graph. So I've already summarized the study, and now we obviously you cannot go around doing liver biopsies, but this very small study of about, I guess, 9 patients or so were followed up by liver biopsy prior to starting empagliflozin. They were all type 2 diabetics. Over 24 weeks, significant reduction in steatosis with just 24 weeks of empagliflozin, 25. And I was keenly listening to Dr. Bansi when he was saying, when he was explaining the graph of how soon the curves start separating. Similarly, 24 weeks is not a very long time. In this, again, you see this kind of benefits. And in this, the time of exposure, if it prolongs, possibly the benefits would be greater. So these patients had a significant reduction in steatosis, ballooning, fibrosis, all these things just over a small period of 24 weeks. Hence, further substantiating the possible benefits or liver protection provided by good. Yeah, thank you. So the next study is focused on GLP-1s, which is the ELIFT study. We have 2 GLP-1s available, lira and dulaglutide. Our study was done on dulaglutide. Just to there was data on liraglutide about its liver benefits, some studies on liver quantification, some histological studies on liraglutide and liver benefit. However, and there are no studies existing till our publication on dulaglutide on liver fat. So this has recently been published in Diabetologia. Here again, liver quantification with MRI was done, and a whole lot of statistics was done. Uh, over 24 weeks, there were 64 patients. Obviously, lots more were enrolled, and those who are interested, I can share the full text article. Very interesting read. What is very important is in day-to-day clinical practice, doing a randomized controlled trial in your OPD setting, and see these are the kind of parameters which we have controlled in the two groups so as to minimize confounders which would lead to changes in the final results. Age matching, gender matching, the diabetes, all these coexisting diseases, their medications. As you can see, both the columns, we tried our best, and it is not easy to do this in your day-to-day busy clinical practice. Uh, Again, baseline parameters, their biochemical profiles of these patients, they ranged, the average A1C was 8.4, and the BMIs were in the obese category for most of them. And these would be the routine kind of indications for using drugs like empagliflozin or dulaglutide. Their liver functions clearly demarcated here. The in between group differences were virtually negligible. The lipid profiles, blood count. So as I said, if you look at these parameters which were done, you would wonder, oh, we all do these parameters in our patients, and that's why I said it is an extremely simple data set which I am sharing. And by doing it and the results we got, it has been very well respected and accepted in diabetes care and diabetologia. So over 24 weeks, I'll reflect on the most important parts or clinically relevant results for us. There was significant reduction in the body weight and BMI. We know that GLP-1 RAs are a group of drugs which have got an excellent profile on weight reduction. And that's how possibly it adds on to the cardiovascular benefits of the drug. So significant differences, the mean differences in the group in body weight was about 2.3 kilograms. Like in the empagliflozin, we saw significant reduction in the GGT levels. Also, if you can see, there were minus levels in all these parameters, reflecting uh, the possibly the kind of near ideal diabetes care being given to all these patients, where the glycemic parameter, whether they receive dulaglutide or the standard of care minus dulaglutide, all these parameters, as we accept, were getting better. Just an extra point here, which is out of the preview of my discussion. The Rewind trial has shown that the renal protection of dulaglutide, though our study was not powered for this particular outcome, but just as a secondary exploratory outcome, we see similar benefits in the urine protein creatine ratio with dulaglutide. So in the publication, you might not find any mention of this parameter or benefit. About nearing 56% of our patients on dulaglutide with standard of care lost more than 5%. And we all understand the benefits of losing this quantity of weight. Whereas in the control groups, better glycemic control and weight neutral or certain weight promoting drugs like sulfonylureas or insulins, there was a significant increase. I won't say significant. 36% patients gained weight in the control group. Now, this is the most important, the primary outcomes of the study: changes in the liver fat, and we also did analysis to look at pancreatic fat content, which is again an interesting and an emerging area. There was a 3.5% reduction with dulaglutide on the liver fat content as estimated by MRI. And we saw in the last ELIF study, there was a 4.2 reduction. The relative change being in tune of 26%. The pancreatic fat, even though lesser, was not statistically significant in the two groups. But if we can see here, the numerical values varying significantly, not statistically, but numerical values differencing. The liver stiffness, or a surrogate marker of fibrosis by the velocity controlled electrography, or the fibroscan, did not show significant differences, possibly the time period being not that long for it to show differences, even though reduction in the liver fat content was happening. Again, a graphical representation over 24 weeks, what happened in the control group, where the velocity of decline was much lesser as compared to the dulaglutide group, where the liver fat content significantly dropped at the end of 24 weeks. Now, we have to go back to the ELIF trial, where we had significant, non-significant correlations with weight loss. With dulaglutide, the liver fat content was very significantly correlated with weight loss, as we can see here, a clear line with greater weight loss, greater liver fat reduction, significantly associated with A1C, as we can see here in the p-value. Reduction in the AST levels reflected in better reduction in liver fat. Triglyceride reduction, again, correlated very well with liver fat. In a multivariate analysis where age and gender were taken care of, triglycerides reduction, body weight reduction, A1C reductions were independent predictors of liver fat content. So this cartoon just summarizes the DLIF trial benefits or reduction in liver fat by quantified by MRI, the GGT levels, no change in liver stiffness, possibly because of short duration of the study, numerically reduction in pancreatic fat, and significant reduction in body weight, along with across the board better glycemic control, which happened in both the groups, because the standard of care was aimed to provide a glycemic equipoise, where at the end of 24 weeks, both the groups should attain the best possible A1C reduction. So strong and clinically relevant were these two studies that in the section 4.10 of the 2021 guidelines, we have the DLIF publication being cited as a part of possible benefits of GLP-1 RAs in diabetes care. And see, that's what completes the justification of today's topic of translating research into clinical practice with such important data set, which has been generated for the first time in our population and being endorsed by the ADA. And we've all been using these drugs, just that we will be more sensitive, and while giving these benefits to the patients who specifically come with these indications, that yes, we have a possible solution of helping you also in this state. So just to complete where Dr. Bansi had stopped, so efficacy in glycemic control, durability of glycemic control, blood pressure reduction, reduction in the weight, reduction in total fat, body weight, kidney protection, hospitalization for heart failure, CV mortality, morbidity, all these reduction. And the next part added to it is benefit on liver fat. Small studies showing possible benefits on liver histology and NFLD. So I conclude here with we've understood a bidirectional relationship of type 2 diabetes and non-alcoholic fatty liver disease, and coexistence of type 2 diabetes and non-alcoholic fatty liver disease increase the risk of complications, hepatic and extrahepatic, in patients with type 2 diabetes, making addressing non-alcoholic fatty liver disease therapy in our patients with type 2 diabetes who have aggregation of these risk factors. Till now, we had very less options in the form of vitamin E and pioglitazone. I have not shared that study, but the PREVENT study did talk about the possible benefits in diabetes with non-alcoholic fatty liver disease with pioglitazone, uh, with SGLT2 inhibitors and GLP-1 RAs has opened up the arena of liver protection in our patients with type 2 diabetes. The E-lift and the D-lift studies, which is our own data emerging from our center and is representative of the patients we treat with significant possible beneficial, long-term beneficial roles of these two drugs in diabetics with non-alcoholic fatty liver disease, and with respect and endorsement being given by the ADA also. However, I conclude here that we definitely need much more long-term and histological studies for these to become drug of choice in non-alcoholic fatty liver disease with type 2 diabetes. I thank all of you for your very kind listening.